Good morning. It is my pleasure to welcome Dirk Brockmann back to Northwestern virtually for today's Dean Seminar Series. Dirk is a professor at the Institute for Theoretical Biology at Humboldt University in Berlin. And prior to his time in Berlin, he was on the faculty here in ESAM, Engineering Science and Applied Math in McCormick. Dirk studied physics and mathematics at Duke and the University of Göttingen, where he received his degree in theoretical physics in '95 and a PhD in 2003. And then he completed postdoctoral positions at the Max Planck Institute for Dynamics and Self-Organization in Göttingen before coming to Northwestern. His work focuses on complex systems, an area that is dear to me, and is particularly relevant to the current pandemic that we're facing. Back in 2009, Dirk, in the good old days of 2009, Dirk received widespread attention for his studies on human mobility and the spreading routes for H1N1 pandemic. He also pioneered the development of computational models for and forecast systems for global spread of epidemics and based on global air transportation. I think that you'll see that Dirk has a compelling way of explaining his concepts and visuals. His work could not be more relevant at this moment, so I'm very, very pleased that he could take time to join us here today. And I can tell you, Dirk, I miss you enormously here in Northwestern, but I'm so glad that you could do this for us. So, Dirk, the screen is yours.
Thank you so much, Julio. I miss you guys too, quite a bit actually. And I'm going to start sharing my screen now so everyone can see what I will be talking about today. Just one second. Okay. Here we go. So first of all, thank you so much for giving me the opportunity to talk again at Northwestern. I'd be very much delighted if I could be there in person. And I do hope that this opportunity will come again in the future. And so then I can actually see you guys and talk to you guys. It's a real pleasure to talk to you. I was very much looking forward to this. And I hope I will be able to give you an overview of our activities in the context of the COVID-19 pandemic. So I'm actually going to talk to you about 4 projects, and all 4 of them would not exist without my time at Northwestern, because the seed of the ideas for these projects was actually born at Northwestern. And I gave this talk the title Understanding the COVID-19 Pandemic because there are various aspects of this pandemic that I will try to unravel and explain, and the different perspectives we use to understand this pandemic better. So I'm going to start actually with a video that Hiroki Sayama did. And it's a very simple fast forward video of the dynamics of the pandemic from the February this year until about September, and it's just an illustration. It's a very simple illustration of the numbers of cases in different countries, and the numbers are encoded by the circles. What I like about this video very much is that you can see dynamics happening. Now, when you look at, when you're connected to the policymakers that look at, their numbers in Germany, for instance, they look at the numbers in Germany and then they see, there's a wave and, what is the situation? But it's always good to have a global perspective, because then you can see what is happening. For instance, in this video, we see, the initial outbreak in China, and then there's outbreaks in Europe, then in the US, and now, about now, you see a second wave hitting Europe, which is still sustained at the moment. And I show you this video because it's very much related to a video that Julio alluded to of a simulation that we did back then in 2009 for the H1N1 pandemic, for the potential spread across the globe of the H1N1, which looks very similar in a number of ways, but also very different. It kind of moves from the left to the right, with an initial outbreak in Mexico, the US was hit, and then Europe, and then Asia. But there are very many similarities, and I'll explain to you in more detail, how one can extract these similarities and how one can see these hidden similarities in these two different situations. Now, just a little bit of an introduction of, what is going on, why are these things happening, H1N1 in 2009 and now the COVID-19 pandemic. One of the reasons there, essentially, when you want to boil it down to what are the main factors of these things emerging more and more, one is urbanization, because more and more people live in cities now. When you just look at the numbers in 2008, now I need to move you a little bit, otherwise I can't see what I'm showing you. In 2008, more than 50% of the human population lived in urban settings, like in cities or big cities. And in 2050, it's going to be almost like 2/3 of the population. And when you compare this to 1800 and 1900, this is a massive increase. So we live in very close proximity. And when we, one of the things that all of these infections share, or the spread of viruses like the coronavirus or H1N1, is from their perspective, I always say they feed on our contacts, because that's essentially what they live off, right? And contacts in urban settings are more frequent than when people live in the countryside. That's one of the reasons. And then the other reason is that there are more and more, even in these urban settings, connections to animal populations that we eat. And many of these viruses, they jump from their animal host to the human host, and that's how many new viruses emerge and then spread in the human population. This was also the case with this coronavirus. And the third part is mobility, global mobility, that also Julio mentioned, that I'm also going to talk a bit more about throughout this talk. This is just an illustration of the worldwide air transportation network, and that kind of captures how connected we are nowadays. We have here about 4,000 airports, about 51,000 connections between these airports, about 3 billion passengers, a little more actually, travel under normal circumstances on this network, and humanity travels about 14 billion kilometers every day. And that's quite a number. It's just, just to have a comparison, it's about 3 times the radius of our solar system. So the 3 times the distance between the sun and Neptune. That's what we travel as a species every day. And so, of course, that has an impact, and you can actually see it in the video that I showed you earlier, the sort of the global picture of the pandemic. And all of these factors are key to the increased emergence of new viruses that spread in the human population. The coronavirus is just the latest and most severe example of a pandemic. Now, I want to look a little bit, like having said these introductory comments about this, I want to look a little bit more into the dynamics and what we can understand about this pandemic. And it was quite instructive when this started in the spring of this year, early this year. When we look at these numbers, there was actually quite a number of things that we were able to learn from the first wave. I call it the first wave, when this pandemic started. So let's look at the situation when there were many cases throughout China, and when we had a few cases also in other countries. So right at the beginning of the first wave of the pandemic, we're talking about like February, March, and April this year. Now, one of the things that we did, and like I mentioned in the beginning, that was based on methods and models that we developed at my time at ESAM and NICO, is related to this project that we did in the beginning when there were only cases in China. One of the things that we tried to do using our knowledge of the worldwide air transportation network and the outbreak locations in China, we tried to estimate the import risk in various countries in the world. This was prior to the definition of this being a pandemic. There were cases and it was unclear whether this were going to be contained. There were already a few cases in other countries. And so we were able to use air transportation and the particular structure in this network to estimate the arrival time and the import risk in different countries in the early phase, because that was an important question prior to the phase where that virus had actually reached every location on the planet. And let me tell you how we did this. So this is a little bit of a rewind to a model that we developed in 2012, actually earlier in 2008, 2009, and then an extension of it in 2013. So it's based on a paper that we did in 2013. And like I mentioned, these were ideas that we developed at ESAM and NICO and McCormick and Northwestern. So that's very important. So what you're seeing is actually rooted in Evanston. So here's just a sort of a very superficial quick run through the ideas of this entire approach. Like I said, the foundation of the model that we introduced back then was the air transportation network. And the essential idea was that we tried to look at this network from the perspective of the virus. And imagine you are a virus on the host, on a human that is located at JFK in New York. And what you don't know and what you cannot control is where that person is going to go next. But there is a probabilistic approach to this. We can say that if, obviously because there's more traffic from JFK to London or to Frankfurt than to say Pittsburgh or Raleigh-Durham, then it's more likely for that virus to, travel to London Heathrow or Frankfurt compared to Pittsburgh. And so we try to define a relation between the probability of going somewhere and a sort of an effective distance between locations, and replace the actual geographic distance, which is part of the traditional way of looking at maps, and replace it with this effective distance. So we try to do something like this to get an understanding of this air transportation network and actually the world, where we replace actual distance with effective distance. In that sense, a person in JFK is closer to London than to say Pittsburgh. So when you do that, and I'm gonna now leave this presentation and open my browser that you should still see, I hope. I'm not having any feedback, but presumably you see my entire screen at the moment. You should see a world map right here, and all the airports. And when we pick a location like Beijing, which is back here, and we change the traditional view of this map and replace geographic distance by effective distance, we get this sort of perspective from Beijing onto the world, where now this radial distance is this effective distance. And we see from Beijing, there are many Chinese locations close to it, but also Chicago or London Heathrow is effectively close to Beijing. And we can also start looking at Wuhan, which was the initial outbreak location right here. Beijing is close, but also Rome, Charles de Gaulle in Paris, London Heathrow, and various other airports. And it actually makes sense to look at this in a linear way, where now this effective distance from the bottom to the top gives an estimate of the arrival time and the import probability at different locations. So that was the general idea. And so let me go back to the slides. But what does that mean? Does that actually have any relevance? And what you see here are two hypothetical computer simulations of hypothetical pandemics that started in two locations. And on the top row, you see a hypothetical outbreak in Atlanta in the US. And on the bottom, it's a hypothetical outbreak on a Greek island. And on the right hand, you see the computer simulation in a traditional, perspective, when we look at a world map the way we're used to, and it looks spatially incoherent and complicated. But when we use display the exact same simulation and use this effective distance, we see a very concentric spread across these nodes. That's what you see on the left. And that's very good, because that means when it's so simple, the spreading behavior, we can make better predictions. And that's how we use this method to compute arrival times and import probabilities during the early phase of the COVID-19 pandemic. Here's again an illustration of this arrival time according to our model in different airports worldwide. And here's Beijing. So that was the first rough idea of analyses and models that we developed during very applied models during the very early phase of the pandemic. And then we looked at this first wave a little bit in more detail. So again, here's the situation. We rewind time a few months into March this year, when there were cases only in China and also in a few other countries in the world, more like February. And here are a number of curves that many of you probably have seen before, the typical curves for example, Japan, the United States, Italy, and Germany. So what you see in these curves are, these are periods in February and March in 2000. The red lines are the dots are data actually, and the lines are from a model that I'll explain in a second. These are the cumulative cases in the different countries as a function of time. And we can see that, in this first wave, there is something that many people refer to as an exponential growth, because that's what you expect from an epidemic that unfolds in an, uncontrolled way. You expect the numbers to increase exponentially, potentially differently in different countries, maybe with different sort of exponential rises, but that's what you expect. And in fact, you can kind of check this. I did this morning. I used Google Trends and put in the German word exponentiell, which is exponential in German, and looked at how frequently that term was used in as a Google search term. And you can see two peaks. One is in March, which was during the first wave, and now in the second wave in Germany, there's still a peak. It's smaller because now people know what that means. But before that, it was, not a common term, but now, during the first wave and also now, people talk about it all the time. Politicians say, we're in an exponential phase, etc., which was not a common term used by normal people outside of, say, engineering or science. And everyone talked about it. The funny thing is that that's something that you would expect from a disease that is transmitted from human to human. So one person meets transmit the disease to another. That person again infects a certain number of others, and then so you see this multiplication, and which generically would yield an exponential growth. The interesting part here is, the interesting thing is, and this is what we did in March, I think, we looked at the numbers in China. So this was a phase, January and February in 2000, the the whole thing was unfolding in China. And we looked at the numbers, and here are very many curves on this slide. So I'm going to walk you through. On the top left, you see the confirmed cases in Hubei, which is the province in China that was the initial outbreak location. And you put the data points on a line, and you see there's a growth. And some people may think it's an exponential growth, but it's actually not. It's an algebraic growth. And that was not only true for this Hubei province, but almost every province in China exhibited as sub-exponential growth. When you just put it on a linear scale, like on a top left, you don't actually see that so well. But when you put it on a log-log scale, you see it's more an algebraic increase. So the number of infections, the cumulative cases, they increase like t to some power, which is approximately 2. It's different for different provinces in China in January and February, but it's roughly of the order of 2. And so this is something that you don't expect from an epidemic that unfolds in an uncontrolled way or in a natural way. Let's put it this way. It's very atypical, but even then, why we were already putting a preprint out about this, but people were still and are still talking about exponential growth. And in some cases, that's actually also the case, but here it was not. And here's just another comparison. This is also the first wave. As you can see, days since January on the bottom on the x-axis. So this is first wave in Italy. And remember that Italy was very much affected by this because they were running out of ICU units in the hospitals, etc. So very dramatic situation during the first wave. But we see on this log linear scale, it's not a line. It's a very interestingly shaped curve. It's actually an algebraic curve compared to the US, which was almost a pure exponential during the first wave. But what we've seen here in Italy and also the other provinces in China was quite generic, that there were very many scenarios where we did not see this exponential scenario, and we were wondering why this was happening. Now, the thing is that when you look at models for diseases, there are traditional models that are often mechanistic, that put equations together that are based on reaction kinetic ideas, transmissions, recoveries, mobility is often involved, and then these models let the disease unfold as if the population were not aware of it. But that's certainly not the case during a pandemic. Often there's if there's the pandemic, then there's news about it, information about it, also misinformation about it, and that triggers psychological processes like risk perception or attitudes towards this burden of disease or the trust in government agencies, all of these things that then change our behavior. And our changed behavior impacts the disease dynamics, which in turn, changes our perception of the disease. And so we have like this feedback loop, and also there's policy involved. It's a unit in the middle that acts on the disease dynamics, for instance, putting equipment into hospitals, but there's also, effects on psychological processes and direct effects on behavior because of lockdown measures, etc. So it's a very complicated phenomenon, which is not entirely a medical phenomenon or a clinical phenomenon. Often in Germany, I know it's perceived like this, but they're just as important psychological and behavioral processes involved, particularly now, but also in the beginning of the pandemic. So if one simplifies this picture a little bit, or let me rewind. One of the things that people usually have at the foundation of all of these models that try to capture the dynamics of a disease is at least some sort of transmission process where a person infects another person, and then there are two infected individuals, and some sort of recovery into an immune state where people can no longer be infected. Now that's a very, very simplistic drawing here, but it's really at the core of all of these models that try to capture disease dynamics. Now, one of the things one can try is to actually close this feedback loop between behavior, which determines how a disease unfolds, and information about the disease and how that may change the behavior. So we tried to see if we could explain the deviations from this exponential growth in the different provinces in China and also different European countries by closing this feedback loop. And so in a very simple drawing, what we did without any math involved, we said, well, if we take a model that involves the basic ingredients of disease dynamics called the SIR model, which is sort of what you see in the middle, you know, there are infections and recoveries. But we say that as a function of how the disease unfolds, people that are healthy and also people that are infected are removed from the population and go into quarantine and or isolation, which was actually put in place in China quite effectively during the first wave of the pandemic, but also to a lesser extent in various European countries. So while the epidemic unfolds, there's a depletion of people that can be infected, either because people start wearing masks or they stay at home, but effectively there's a depletion of susceptibles. And when you really write down the simplest type of dynamical system that can capture this, what you get is a non-exponential increase in the beginning, but rather an algebraic increase, and actually with this power of 2 as slope and or exponent. And so we then put this together, and it was shortly published in Science shortly after this. And the key ingredient here is that this model was very simple and could generically extract like these universal features of these increases, sub-exponential increases in these provinces in China and also many European countries. But it didn't work in other scenarios because this feedback has to be closed in a specific way. So the depletion of susceptibles has to occur in a certain functional relationship to the disease. When it's too small, then you will still recover exponential growth, as for instance in the first wave in the United States. So that was one of the projects, and it was also essentially initiated by ideas that we developed at ESEM when we talked for the first time in a totally different context, when it was about vaccination, about closing this feedback between disease dynamics and behavior. Now, another project is this one. It's very applied. It's a project that we did also in the COVID context, and it's very applied to the German situation. So what we did is we got together with some of the phone companies, and they donated essentially all their localization data of all the cell phone users in Germany to us, which was, ended up in the media because of privacy issues involved, but they actually gave us data that they also sell to other customers in an aggregated and anonymized way. So the data looks like this. It's essentially spatially highly resolved data on how people go from A to B in Germany. So the map that you see is Germany, and the little patches are counties in Germany. There are about 300 of them. And this data is hourly resolved movement patterns within these counties and across these counties. And the patterns that you see at the moment, that's how people travel in Germany under normal circumstances. On the top right, you see Berlin. It's this little star there. Lots of mobility in Berlin. On the west, you see the highly densely populated area of West Germany. And we set up this site called the COVID Mobility Monitor, and it monitors the mobility and updates the data every day. This was quite some engineering work we had to do there in order to set up a website that monitors the mobility in Germany and puts it online for everyone to look at and is updated daily. So let me show you some of the things that you could see. One of the things that we focused on in the beginning of the pandemic is how mobility changes as a function of time during the first wave. Now, these are weeks 11, 12, and 13 in Germany. So this is during the first wave. And in early March, you kind of see normal behavior, which is kind of yellowish. That's sort of compared to 2019 in the same period of time. So that's normal mobility. And then in week 12 and 13, this was when lockdown measures were put in place all over Germany. I have to tell you that Germany is has federal states, and they have lots of power, and they make their own decisions. And there's always lots of fight among the governors of the different states of what to do, because some areas are tourist areas, etc. So they never agree on anything, but here they agreed to impose a nationwide lockdown. And we, saw that in the mobility, obviously. And here it's a little bit as a function of time during February and up until April. So the black curve that you see is the mobility, all over Germany. So it's like the nationwide mobility. And there are fluctuations. And then the red lines are lockdown measures that were put in place. For instance, the first line is a speech that Chancellor Merkel gave, and advising people not to travel. And then it decreased up to down to 40% within 2 weeks. And so all of these lockdown measures were put in place and mobility decreased. And then interestingly, even in a period when these mobility restrictions were still put in place, the curve already increased and went back to normal. The green lines are release of lockdown measures. And it took until a month or so later when people were back to normal, and this was after the first epidemic wave. So one of the things that we're using this mobility monitor is to measure how effective lockdown measures are, but also in what way people react to news about the epidemic and independently of lockdown measures. Here's a little bit more detail about what we can do with this data. This is the change in mobility grouped by distance. So, and we just confirmed the sort of common sense notion that people travel long distance, reduce their long distance traffic more than their short distance traffic. This is important from an epidemiological point of view, because if people just, stop traveling long distance, but are still as mobile within their county, there's not much gained if the virus is already everywhere. One of the things that I found interesting was came out of a collaboration with a public health psychologist. Her name is Cornelia Bitsch. She does amazing work on the perception of, in this case, the COVID-19 pandemic, on attitudes, etc. And she did survey work in which she asked, as a function of time, individuals in Germany, do you think the restrictions are too harsh? And that changed over time. That's the green curve, and it coincided quite well with the change in mobility. Also, the move back to normal mobility coincides with this, and so there seems to be a strong connection between the attitude and the behavioral changes induced during the first wave. And we also saw some topological feature changes in the entire mobility network as a function of time. So distance, this effective distance that we used for the air transportation network, changed during lockdown quite a bit. And one of the things that we looked at, this is again modeling, is how the change in the pre-lockdown and the lockdown mobility network would impact the speed and rapidity with which an epidemic wave would go through the country. and just to clarify how much like mobility changes impacts the dynamics. So this was during a debate when it was about flattening the curve and slowing down the pandemic. And we were able to just sort of quantify this using this German-specific mobility network analysis, but there were other studies that did the same in Spain and France with very similar results. Now, finally, I want to talk about a project that is totally different. This is, interestingly, we have discussed similar things also in my time at ESAM when we discussed the idea of data donation. And I'm going to explain to you what I mean by this. But I remember having discussions at NICO and with various colleagues at ESAM, how great it would be if one could implement an infrastructure in which individuals donate digital data that we could use to gain more knowledge about how we behave and how we interact. Because all of these things are important, not only in the context of disease dynamics, but in a broader context. And in January, in the Lancet, this paper appeared, and in this paper, the authors from Scripps, Eric Topol and Steve Steinhubel and others argued that one can use smartwatches, like the Apple Watch and other fitness tracking devices, in order to estimate and measure whether a person has a fever or not. And based on this idea that was more formulated in the influenza context, so this was before COVID, this is the basic idea of a project that we initiated during the first wave of the pandemic in a very, very fast way. The idea that there are about 10 million people in Germany that have such a watch that measures heart rate and daily step count and sleep rhythm, etc. And maybe we could use this in order to establish a data donation project in which people donate this data, and then we could develop something like a fever thermometer for the entire country. And so that was the idea. And so I have to apologize. Some of these slides are in German because it's a project that is done in Germany, but I'll translate everything. So we initiated this Corona data donation project because that's, I think, in principle, it's not only an idea that is valuable for the Corona crisis, but in general could be sort of a template for projects of this sort in the future. You can go to the site if you like and see our science blog about it, but the idea is this. So we programmed an app for all the phones, and you could download it, and then this app talks to your fitness tracking device, and all your daily heart rate data and your step counts are donated to us. And then we can analyze it and determine whether, with a high likelihood, you have developed a fever or not. And so that's essentially how it works. You download the app, and you allow us to download the data, and you tell us where you live and some of the other information like age, etc. And so we started this in a country that is very careful about sharing data. So there's like data protection is a very high value has a very high value in Germany, and people are very hesitant to do stuff like this. So that was the greatest hurdle that we had to take. But nevertheless, during the first pandemic, we were able to recruit more than 500,000 donors. And so that's a massive amount of donors. And you have to imagine that they're all distributed in the country, and we can measure their fever. And that's what we did. And here again, and because it's a participatory experiment, we wanted to have a channel by which we can inform all of these people that donate their data and give them, updates about our research and also intermediate steps, and not just have this data and disappear with it, but we wanted to have this a very open process. And that seemed to have worked very well, because they're still with us, all of the 500,000 donors. So let me give you a little bit of insight what we gained here. So here's the basic idea. So if you look at the top plot, every individual has donated now many data points of heart rate and step count. And every individual has a individual specific baseline for the typical heart rate, which may vary. It may be on one day a little higher than on the other day. There are also gaps in the data. And there's a person-specific typical step count, which is even more variable. But when you look at it over time, there is a typical value, around which the signal varies. And what happens when people develop a fever is typically their heart rate, their average daily heart rate goes up because they have developed a fever. At the same time, they tend to move less because they're sick, they stay at home, they don't walk, etc. And so we take these 530,000 signals and then we try to find exactly these situations. So it's a little more complicated than I just explained, but in essence, that's how it works. There are also traces where people, for instance, have an increased heart rate, but they also move a lot. This could be sort of a bike trip on the weekend. So we look at specifically when heart rate goes up and step count goes significantly down. And because you have so many people, in the aggregate, you can see a signal. So that's the basic idea. And here's just a little bit of a collateral insight that we gained, which kind of hit the media back then, as a comparison, sort of as to make sure that we're making no statistical error. We just computed the heart rate, the resting heart rate of the population in different counties in Germany. And I actually expected a uniform map, kind of sort of a sanity check here. But we found, and medical doctors were very keen looking into this, we found a significantly higher resting heart rate in the population in East Germany compared to West, with a few exceptions. And it's still unknown why this is. There are various hypotheses about these, about like the different age structure, which we filtered out, but also, different diets in East Germany, but we feel like we still see a cultural difference between the East and the West here, which is why this had a political twist to it. I didn't expect it, but it, this map kind of went around the media because it was another indicator that there's still, after 30 years of reunification, a difference in East and West Germany. But this was not what we were after. We wanted to see whether our fever curve would be a good predictor of the time course of the epidemic in Germany. And that seemed to be working. So what you see in this curve is the first wave and now the second wave in Germany. And the blue curve is our fever measurement, like the detections of positive fever cases among our donors. And what it looks like that we are a little bit ahead of the reporting system, in the sense that, we measure the fever of these individuals every day. And when people get sick, they don't go immediately to the doctor. They may wait for a day or two on average. It seems like the curve, this fever detection curve, is a little faster than the German reporting system, which is, for instance, slow on the weekend, etc. So the hope is that we can see turning points, etc., in the case counts quicker. And so this data donation project has become a part of the German situation assessment. But it was a long journey because the traditional epidemiologists, they thought we were crazy doing this, but it seemed to be working. And we have this, the automation process was again an engineering work that we had to do, which was crazy because every day we download the entire data from all of these watches. We have to pre-process and filter it, etc., apply our algorithms, and then on an automatic level have this fever monitor that is online. So every day, this whole process of the data measurement and filtering, etc., that I just described is done automatically. And the fever curve, the fever curve for Germany is updated daily. So that's an entirely automated process now. And we're in touch also with the people at Scripps, like Eric Topol. He likes the project, and others. And we're trying to set up a collaboration here. They just published a Nature Medicine article on their findings. But I was very happy when you read this paper, they mentioned us as the largest effort that was developed by us, and we have enrolled more than 500,000 volunteers. They only had 30,000 or something. And it is a little ironic, because this sort of thing we didn't expect to work in Germany, where people are very reluctant to share their data in this way. So I'm going to end with this, and I thank everyone for their attention. I hope I was able to keep you alert, and I hope you learned something and enjoyed the talk. Thank you very much.
Well, this was a fantastic talk, Dirk, and I was not wrong in saying that you'll have very compelling visuals, but this was a very, very nice tour de force, really.
Thank you.
I want to remind the audience to use the Q&A to submit questions, and so the system is open now, and I think some people in my team will see the questions, and Eric will see the questions as well. So you can start sending whatever things occur to you for Dirk to answer.
So I'm just going to go, right? Because I see in the Q&A, I see a question by a good old friend of mine, Christian Weppe, in the US. I don't. So the question is, and does everyone see it, presumably, or should I read it? Okay.
You can rephrase it if you would be good.
So the question is, are you aware of the Kinsa smart thermometer data in the US? Have you compared your data with theirs? No, I don't. We do have a connection to the Scripps people, and that also use wearables, but I'm not aware of this. Thank you.
So can I ask something? Well, there is another question in there, but regarding the simplified model in which you had the dynamics interacting with the behavior, which is the ultimate complex system, really. What is the most advanced thinking in regards to modeling coming from that incorporates behavioral changes coupled with how the dynamics of the pandemics is evolving? Any other place besides your group?
I think there are more and more people thinking about this, but there's a lot of motion. But I would say it's still among the modelers not so ingrained, because it's really what is happening. It's an integration of natural sciences and social science. Mm-hmm. And as far as I can tell, especially like working with traditional epidemiologists, they're not there yet. And modeling does some of it, but also it's done more in a very explicit way, in a sense that many people do very detailed models that incorporate a lot of fine-grained components that then intrinsically do this. Individuals, like in an agent-based simulation, they respond to the situation, so there are rules, etc. But in terms of dynamical systems approaches, I don't see so much. But this coupling is still underrepresented in the disease modeling community, I think, as far as I can tell.
Great. So there are several questions in there, so I let you handle those.
Yeah. So the Jacob Kelter asks, do you have any idea about what was different in the US information environment such that the growth was exponential here and not in other places? I love this question because I've been asking myself this too. And there are also similarities in the first wave between the UK and the US. And also the contrast to many Asian countries like South Korea, Malaysia, and other places where the dynamics was entirely different. And there, when you ask people, you know, what are the reasons here and there, it could have been, you know, easy adoption of wearing face masks, a more uniform, non-polarized society, or electronic track and trace methods. There are many factors that could be different, but I wonder, and so my hypothesis is always, and I know this from a vaccination study, that in many countries, or in countries that are very individualistic, the disease unfolded more strongly. And in countries that are more collectivistic, if I don't know if that is a word, but apparently there's a way to quantify this, it unfolded less so. So when people are aware that they can infect someone else, if that awareness is dominant in their behavioral changes, it is less dramatic. And there's one study that I know that is looking into this, and that could be part of it. But it's certainly the quick response for many European countries and the quick adoption of containment measures like wearing face masks and other lockdown things, you know, things that limit your personal freedom. So I hope that answered the question. And then there's Matthew Grayson. Are there any factors that might change the universal power law exponent from 2 to some higher or lower value? That's a good question. Also, there seems to be, so there are different parameters in this model that end up determining this exponent. And yes, there are different values that you can reach. There's a range of them, and there's also a transition to an exponential growth, which is related, like many factors, many parameters are involved in determining this exponent. Avi Feingsicht, any interesting studies at the intersection of COVID modeling and natural experiments? I'm thinking about, for example, studying mobility at the border between France and Germany or other boundaries where the policies might be significantly different. That's also a great question, and also something that we looked at when we looked at the mobility in Germany, especially at the borders. And an interesting anecdote here is that when we did this mobility network, during the mobility analysis during the first wave, different ministries were interested in our work because they were interested in movements across boundaries, vacationing, etc. And the effect of closing national borders, that is always a big issue in Europe during the pandemic, and whether this would have an effect. And so and this is something that we saw the effect at the national boundaries in response to closures. And unfortunately, there's no European mobility network analysis. So these networks are connected, obviously, but there's no one who has connected them yet. So we cannot answer some of these questions. Sean Malcolm, is there anything you can predict for the second wave from your data? So at the moment, we're working at a an extended model that is also using this feedback loop of disease dynamics and behavior that incorporates something that's called corona fatigue. So the psychologist that I mentioned earlier, she also looks into something called corona fatigue, that is how our risk perception changes gradually, how we get used to the situation, and how the situation gets on our nerves, to put it this way. And so this corona fatigue is increasing gradually over time and may have caused the second wave in many countries, because, you know, in a sense, the second wave is, we know it already. You know, it's just another pandemic wave, and we're not as scared anymore. And we incorporated this into this model, like a gradual change, which then generically shows a higher second wave than the first one, which is also what we observe in many countries. So we have a more closed feedback loop in this model, and we're writing this up at the moment. Caitlin, have you considered the possibility that, especially in the first wave, the disease could have grown faster than the increased rate of testing? So the positive test results could be lacking something in how the disease actually grew. That's also a good question. I can answer that for Germany. I don't know how the situation is in the US. So the testing was quite dynamic in Germany, especially during the first wave. But we have learned quite the impact of testing during the summer and the second wave, where the testing was for some period fairly constant and then increased by a step, and had an impact on the case count. I remember there was also a discussion in the US that, you know, the situation is so bad because there's testing so much, which is nonsense. But there was a discussion about this in Germany too, and you do see an effect, but it's very tiny. And but for the first wave, second wave comparison, what you can look at is the positive test rate of the tests that you have done, and also in that or the hospitalizations, and also there you see a difference. I hope I answered that question. It's still there. Now it's gone. David, as for your fever tracking, do you have a model for how the normal seasonal flu will impact those numbers in addition to COVID? Yes. So that's a good question, because fever is obviously not only a COVID-19 symptom, but also related to flu infections and many other infections, in fact. And so at the Robert Koch Institute, where we do this, there's also a influenza monitoring tool, which is the traditional surveillance system that they've got. And we have to factor that in. And at the moment, we can rule out that this is caused by influenza, because the influenza wave has a tiny little impact on, and when you add it to the COVID cases, it's almost the same. So it's not a strong impact there.
So Dirk, we are kind of reaching the boundary of the time, and I can tell you, speaking of peaks, this was a peak attendance for Dean's seminar series, and for maybe all the other Zoom talks we have had connected with McCormick. But I want to thank everybody in the audience and for having connected with us. And Dirk, I'm so grateful that you could take the time to.
It was a real pleasure.
It was fantastic talk. Hopefully the recording worked well, and we will have the talk for everybody to have a second pass at it.
Yes.
Thank you so much, Dirk. Okay.
Thank you, Julio, for having me. And next time I'll be there in person.
Fantastic. Hopefully. It's a date. Okay. Bye-bye.
All right. Bye-bye.